Good afternoon, everyone, and welcome to this second concurrent oral abstract session of the Epi and Public Health track. My name is Lawrence Wagbo. I am a research methodologist and associate professor at McMaster University. We have an exciting lineup of speakers. So what's going to happen is each person will talk for 10 minutes, and then we'll have 5 minutes of questions and answers. And feel free to put your questions in the chat, and I will read those questions out to the speakers. So without further ado, I will introduce our first speaker, who is Anthony Y. Nguyen from the University of British Columbia. Anthony, you have the floor.
Perfect. Thank you so much, Lawrence. I'll just get started with presenting my slides. Awesome. Are we good to go with the slides there?
You're good to go.
Perfect. Good afternoon, everyone. My name is Anthony Nguyen. I'm an undergraduate student at the University of British Columbia. And I would first like to acknowledge that I'm presenting today from the traditional, ancestral, and unceded territory of the Musqueam people. Today, I'll be presenting to you the perceptions of and changes in amphetamine use among gay, bisexual, and other men who have sex with men, or GBM, in 3 Canadian cities. Crystal meth is an amphetamines-type stimulant, and its use remains fairly uncommon among the general population in Canada, but high prevalence of use has been reported by GBM in Canada. GBM often report using crystal meth in sexual context to enhance their sexual experiences, as some of its reported effects include increased sexual confidence, disinhibition, and arousal. Crystal meth use among GBM have also been associated with increased likelihood of HIV transmission and poor adherence to antiretroviral therapy. Currently, few interventions exist to address crystal meth use, and a lot of these interventions have only limited efficacy. Therefore, in our study, we had the 3 research objectives. First, we wanted to assess attitudes of GBM towards their own substance use. Next, we want to examine factors associated with reporting needing help reducing substance use among GBM who reported recent amphetamine use at enrollment. And third, we wanted to examine factors associated with reporting reduced amphetamine use at follow-up study visits among GBM who report use at an earlier visit. To do this, we drew data from Engage, an ongoing biobehavioral cohort study of cisgender and trans GBM in Montreal, Toronto, and Vancouver. Recruitment took place from February 2017 to August 2019 using respondent-driven sampling. And GBM were eligible if they were at least 16 years of age or older, self-identified as a man, reported having sex with another man in the past 6 months, and lived in one of the data collection cities. Our baseline sample consisted of just under 2,500 GBM, of which 1,179 were in Montreal, 517 in Toronto, and 753 in Vancouver. Participants completed a computer-assisted questionnaire in French or English at enrollment and at follow-up visits every 6 to 12 months. The questionnaire included measures asking about whether the participants had used amphetamines in the past 6 months, including ecstasy, crystal meth, methadone, speed, and non-prescription use of psychostimulants such as Ritalin, Adderall, and Concerta. GBM who reported any amphetamine use in the past 6 months were asked about how frequently they used amphetamines, with the following 4 response options. And for our analyses, we defined a reduction in amphetamine use as a decreased frequency of use at subsequent study visit. We used the following 2 questions to assess GBM's attitudes towards their own substance use. We asked to what extent that they felt they needed help in reducing their substance use within the previous 6 months with the following 4 response options. And we defined needing help reducing their substance use as an individual who selected a lot or completely as their option. We also asked participants to rate the extent to which they felt that they had an amphetamine use problem and their readiness to take action by selecting one of the 5 response options. And we defined viewing their amphetamine use as problematic if they picked any of the 4 options that included a statement, I think, or I know I have an amphetamine use problem. This question was asked in enrollment and follow-up visits in Vancouver, but only at follow-up visits in Montreal and Toronto. For statistical analyses, we looked at GBM who reported past 6 months amphetamine use, and we first conducted a cross-sectional analysis using RDS-weighted logistic regression to identify associations with reporting needing help reducing substance use in the past 6 months. Some of the explanatory variables that we explored for our model included sexual and substance use behaviors, mental health symptomatology, and other socio-demographic factors. Next, we conducted a longitudinal analysis comparing follow-up visits with earlier visits using mixed effects logistic regression to model associations with reductions in past 6 months amphetamine use. This included follow-up visits from February 2017 to November 2020. And our primary explanatory variable of interest was current amphetamine use view, where we compared participants who viewed their amphetamine use as problematic or not. At enrollment, 727 GBM, or about 30% of our participants reported past 6 months amphetamine use. And the following table presents some of the baseline characteristics, including amphetamine use frequency, where we see that just about 60% reported using amphetamines once or twice in the past 6 months, and there were no significant differences between cities. So most of the participants use amphetamines quite infrequently. In terms of needing help reducing substance use, less than 20% of the GBM in each city reported needing help, as indicated by the responses for a lot or completely. And we did observe some differences between cities, and you can see in the bottom right, the differences seem to be coming from Vancouver. For our cross-sectional analysis, this table presents the results for that, where we compared 107 GBM who reported needing help reducing their substance use to 608 who did not. And in our final multivariable model, we found that GBM who reported having group sex in the past 6 months, having more escape-motivated substance use behaviors, having greater anxiety symptomatology as indicated by scores greater than 11 on the HADS anxiety subscale, having ever accessed drug-related services, or those who reported greater financial strain were more likely to report needing help reducing their substance use. In our longitudinal analysis, we compared 534 study visits where participants reported a reduction in their amphetamine use to 609 visits where no reductions were observed. We found that reductions in amphetamine use were associated with GBM's attitudes toward their own amphetamine use, where we saw that GBM who reported that their amphetamine use was problematic had lower odds of reductions in use over time. In addition, we also found that GBM who identified their ethnicity as African, Caribbean, or Black, and those who reported recent ecstasy use in the past 6 months also had decreased odds of reduced amphetamine use. Overall, we found that GBM who use amphetamines use it infrequently, and the majority of them, or about 85%, don't feel that they need help in reducing their substance use. We also found that the GBM's attitudes toward their own amphetamine use was associated with reductions in time, and reductions in use over time, along with ethnicity and recent ecstasy use. This may highlight a need for more health promotion and education on amphetamine use in the community, and GBM who are less likely to reduce their amphetamine use may also face barriers or inequities in accessing care. So it's important for us to ensure that GBM who want to access interventions are able to do so. Despite GBM living with HIV reporting more crystal meth use, we did not find that GBM living with HIV were more likely to report needing help reducing their substance use, and self-reported HIV status was not associated with reductions in amphetamine use. Our study had a number of strengths and limitations. First, our use of respondent-driven sampling and a recruitment in multiple cities in Canada provided us with a large and diverse sample that is likely more representative of the GBM community. Our study also focuses on aspects beyond just frequency of substance use, looking at attitudes that GBM have towards their own substance use. This contrasts previous studies where they often examine GBM's attitudes towards substance use by GBM in general, or examined problematic substance use as assessed by clinicians. In terms of limitations, a current amphetamine use question was not asked at baseline for Montreal and Toronto, so we were unable to include it in our cross-sectional analyses. However, we found that our needing help reducing substance use variable was collinear with our current amphetamine use question, which justify our use of it in our baseline analyses. We also examined all of our amphetamine type stimulants together rather than just looking at crystal meth specifically, which may have obscured some significant differences between different types of amphetamines. As well, there may have been a lack of nuance in our analysis of reduction in use, since participants were asked to pick one of only 4 binned frequencies of use rather than being able to give a precise number for their frequency of use. I'd like to thank all of our engaged study participants, office staff, and community engagement committee members, as well as our community partners. And thank you everyone for your time today. I'm happy to take your questions.
Wonderful. Thanks a lot, Anthony. I am looking in the chat and I do not see any questions, but I do have 2 questions for you. The first is regarding the choice of cities in which this research was conducted, Toronto, Montreal, and Vancouver. Is there any particular reason why you chose only those 3 cities? And the second question is, I'd like you to comment a little bit more on the methodology of respondent-driven sampling. Thanks.
Sure. For your first question, I actually was not involved in the conceptualization of the study, so I don't know specifically why we choose these 3 Canadian cities, but I think it may be because these are 3 of the largest cities in terms of population in Canada, and studies similar to these have been conducted in these cities, so there is also some experience with our different researchers in these cities. And for your question on the respondent-driven sampling, did you have a specific question about that?
Yes, can you describe for the audience exactly what it entails? How do you do a respondent-driven sampling?
Of course. So this is a modified way of referral sampling, or similar to snowball sampling, where we first recruit a number of seed participants. And these participants are selected intentionally based off of a variety of different factors, including consultation with our community engagement committees. And those seed participants have a number of coupons that they're able to use to recruit different GBM that they know in their social circles. And then each participant that gets recruited to the study also are able to recruit other GBM that they know in their social circles using these coupons as well. So this way, it allows us to reach more harder to reach populations because we're using the social and personal networks of GBM to recruit people that they know that may be eligible for the study.
Okay, wonderful. Thank you very much. There are still no other questions, so we will move on to the next presentation. Thanks, Anthony. So the next talk will be done by David Zamar from the University of British Columbia and Sherry Puyak, who will be joining him. They'll be co-presenting, and they'll be talking about the CEDAR project, understanding the systemic social determinants of non-fatal drug overdose among young Indigenous people who use drugs in BC, Canada. Sherry and David, you have the floor.
Thank you. I'm just gonna share my screen here. Oh, I think I'm sharing the wrong one. Just give me a second. Oh, sorry. I figured this out earlier and now hang on. There we go. Okay. Thank you so much for having us present. And we are going to be talking about the CEDAR project, which is understanding the systemic social determinants of non-fatal drug overdose among young Indigenous people who use drugs. And I apologize, my notes and my screen are changing on me. So, but we want to begin by our presentation by honoring the participants who have passed away, and one of our partnership members who passed away in 2018. So since CEDAR project has started, there have been 123 participants who have sadly passed away. Since 2021, when we started kind of gathering more and more information about this, there 85% of those who have passed away have been to fentanyl. So we want to acknowledge their time and energy and stories of their sharing who they are, participating in the CEDAR project for as long as they did. Preston Guno was one of the CEDAR project partners who passed away in 2018. And we just always like to acknowledge his time and energy, as well as the elders who govern our study, who continue to provide the support that we have. I'm one of the partners, as you will see here. In the top corner there is the partnership as a whole. So there's our elders, there's some of the community members. So the CEDAR project is an Indigenous governed longitudinal cohort study that has been going on since 2003, so 18 years. It has involved over 800 Indigenous people who use drugs in Prince George and Vancouver. And the picture at the bottom is the staff at the CEDAR project office in Vancouver. They do incredible work, and it's always important to acknowledge their relationship that they develop and build with our participants. So follow-up interviews are conducted every 6 months with questionnaire and HIV and HCV testing. So please forgive me, I have to look at my other screen for the information here. I can't figure out how to switch them. So for this one, we're going to talk about cultural connection and resilience. And it found that Indigenous traditions, languages, culture, and spirituality have survived and continue to form the basis of resistance and resilience among young Indigenous people who use drugs. Over 40% of CEDAR participants reported knowing how to speak their language, grew up in a family environment where traditional culture was followed, and they participated in traditional ceremonies. CEDAR participants demonstrate high levels of resilience with a mean score of 61.9 at baseline. In previous CEDAR work, resilience was strongly associated with knowing how to speak a traditional language and living by traditional culture. So here's, we're going to talk about the methods. So there were 471 participants who had at least 2 follow-up visits between November 2010 and October 2016. We used David used the Prentice, Williams, and Peterson conditional probability model to examine factors associated with non-fatal overdose. And results were adjusted for location, age, and calendar year. Using multivariable final models were obtained via stepwise variable selection. So non-fatal overdose counts, there were 105 non-fatal overdose doses reported among 471 participants with 2,237 follow-up visits. The rate of non-fatal overdose per study for men and women was 4.7%. Overall, over a median of 4 visits, so 71 or 15.1%, participants reported at least 1 non-fatal overdose, and 23 or 4.9% more than 1 non-fatal overdose. The overall incidence of non-fatal overdose was 9.5% per year for men and for women. Sorry, my apologies, my dog is loud. Among women, homelessness, experiencing violence, sexual assault, sex work, suicide, psychological distress, injection drug use, particularly opiates and crystal meth, trying unsuccessfully to access treatment, needing to help to inject and admitted to a hospital, were associated with non-fatal overdose at the 5% significance level after adjusting for age, location, and calendar year. We want to preface this by saying these key findings that the CEDAR project started administering the measure of Indigenous races and experiences instrument in 2017, following the collection of the data that was used for this analysis. Ideally, this not investigate the impacts of access to healthcare without considering racism and discrimination. So we just wanted to highlight or I guess maybe not highlight, but indicate that racism and discrimination were factors in especially things like trying to access treatment, healthcare, that sort of thing. And there'll be more of that coming in other presentations and papers. In the final model for women recently experiencing violence, thinking about suicide and injection drug use, particularly opiates and crystal meth, were found to be significant risk factors for non-fatal overdose. The risk of non-fatal overdose is threefold greater for women living in Prince George compared to those in Vancouver. The risk of non-fatal overdose was 6.63-fold greater for women who use injection opiates in the past 6 months compared to those who did not. The risk of non-fatal overdose was 1.8-fold greater among women who used injection crystal meth in the past 6 months compared to those who did not. The risk of non-fatal overdose was 1.97-fold greater for women who used non-injection drug use in the past 6 months. The risk of non-fatal overdose was 2.09-fold greater for women who had thought about suicide in the past 6 months. And having recently been in an alcohol or drug treatment program was found to be a protective factor against non-fatal drug overdose, reduced the risk by almost half. So non-fatal overdose association results for men included homeless, thoughts of suicide, attempted suicide, injection drug use, particularly opiates, cocaine, and crystal meth. And psychological distress were risk factors for non-fatal overdose. While speaking a traditional language at home was a protective factor against non-fatal overdose after adjusting for age, location, and calendar year. In the final model for men, homelessness, having been taken from a biological parent or parents, and recent injection drug use, particularly opiates, were significant factors for non-fatal overdose. For men, age had a protective factor against non-fatal overdose. Each year of age decreased the risk of non-fatal overdose by 13%. The risk of non-fatal overdose was 8.2-fold greater among men who injected in the past 6 months. Injecting opiates in the past 6 months increased the risk of non-fatal overdose by 3.61-fold. The risk of non-fatal overdose was 2.11-fold greater among who had slept on the street for more than 3 nights in a row in the past 6 months. For men, the risk of non-fatal drug overdose increased 49% each year between 2011 and 2016. The risk of non-fatal overdose was 2-fold greater among men who had been taken from their biological parent as a child. For discussion, our findings highlight the adverse role of structural violence and the protective role of Indigenous language on non-fatal overdose among young Indigenous people in BC. We want to highlight barrier-free access to culturally safe resources that support healing and coping with grief for Indigenous people are urgently needed. Really emphasizing an culturally safe approach to care. That systemic racism remains a significant barrier to good health for all our participants. I think, thinking about the In Plain Sight report that was released a couple of years ago, participants in a recent CEDAR HCV intervention study voiced that being treated with dignity and respect was essential in supporting engagement. And an Indigenous-led and culturally centered harm reduction response supports will be essential in addressing this overdose crisis. So, just reiterating that when working with Indigenous people, we need to incorporate a culturally safe approach to providing care in all aspects. And if you have any questions, just want to thank you for listening. And if you have any questions, David will be happy to answer them. I can answer around the partnership and some of the work that we do, but David is the data scientist who put all of this together. Thank you.
Excellent. Thanks, Sherry. Thanks, David. I do not see any questions in the chat, but I do have a few questions which might hopefully help clarify some of the things that you presented. In the opioid literature, non-fatal overdose is a risk factor for fatal overdose. Do you have any data on fatal overdoses, and do you think they're connected in this context? We can't hear you, David. We still can't hear you. In the meantime, there is a question that has come up in the chat, and it is the likelihood of speaking an indigenous language associated with age?
Well, David's figuring that out.
Lord, are you able to hear me now?
Yes, we can.
Okay, very good. I just switched my mic to I switched from the headset to my camera mic because I'm not sure what was going on there. So your first question, Lawrence, was around fatal overdose and whether or not we have data on that. And we have collected data on fatal overdose, and that will be in an upcoming study by Cedar. Yeah. So that information will be presented afterward, after. Yeah. We're currently just working on non-fatal overdoses at the moment because that was what was collected through the questionnaires where we asked participants whether or not they had overdosed in the past 6 months. Yeah. Mm-hmm. And I didn't catch your second question. What was that?
Yeah. Is the likelihood of speaking an indigenous language associated with age?
Associated with age. So we haven't looked at interactions with age and whether or not speaking traditional language, but that one I think was whether or not you spoke a traditional language when growing up at home. I think that was the variable. Is that correct? Right? Is that correct, Sherry? Yeah. Yeah. So it's not. Yeah. So it doesn't have to do with the current age of the participant, but it had to do during when they were growing up. Yeah. Mm-hmm. So that was found to be protective. Yeah. Mm-hmm.
Okay. Wonderful. Thank you. Thank you very much, David and Sherry. That was an excellent and insightful presentation. We will move on to the next speaker, who is Kathleen Kenney from the University of Manitoba, and she will be talking about the association of illicit fentanyl use with injection risk practices among people who inject drugs. Kathleen?
Hi, thank you for that introduction. Just gonna get my slides ready to go. Hi, good afternoon, everyone. The title of my presentation today is the Association of Illicit Fentanyl Use with Injection Risk Practices Among People Who Inject Drugs. As an opening to this presentation, I want to acknowledge the land that I'm on today, which is the land of the Mississauga of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples. This land is also where the research I'm going to be discussing today was conducted. And as a settler, I recognize the responsibilities and commitments that flow from my position as a guest on this land, including upholding the Dish with One Spoon Treaty in all my relationships with the caretakers of these territories. So first, I'm going to provide some background context for the results I'm going to share today to help frame how we got to this research question. So Canada is experiencing an overdose crisis that has escalated dramatically in the past 5 years and taken close to 30,000 lives in that time period. Illicit fentanyl is responsible for a majority of opioid overdose deaths in Canada. And as you may know, fentanyl and related analogs are highly potent formulations and are predominant in the unregulated drug market, having supplanted heroin over the past 7 years in much of Canada and the US. A few previous studies have also indicated that fentanyl injection may be linked to increased syringe sharing. Sharing of injection drug use equipment is a predominant route of HIV and HCV transmission. And globally, prevalence rates of HIV and HCV are disproportionately high among people who inject drugs due to adverse risk environments and structural barriers, including the lack of access to sterile injection equipment, poverty, and policies that criminalize drugs. So of the handful of studies, moving to my next slide, of the handful of studies focused on the relationship between illicit fentanyl and injection drug use practices, most have hypothesized that the mechanisms underlying this relationship have to do with fentanyl's shorter duration of effect, which in turn lead to more frequent injection, a greater likelihood of sharing injection equipment, and an increased number of viral exposures to HIV and other bloodborne infections. But these hypotheses have not directly tested in quantitative studies these relationships between fentanyl use and injection risk practices. So that relationship remains unclear. And to help fill this gap, there's a need to better understand whether it is the presence of fentanyl or the frequency of fentanyl that may be associated with higher injection risk practices. And understanding this relationship is important because it may lead to more tailored harm reduction efforts to meet the needs of people who inject fentanyl. So the aim of our study, the aim of this analysis was to examine the association between the frequency of illicit fentanyl injection with the sharing of injection equipment, including syringes, filters, and cookers. This analysis used cross-sectional data, and it's part of a broader community-based project in Toronto that aimed to understand the health effects of cumulative exposure to fatal and non-fatal overdose in the context of this overdose crisis among people who inject drugs, including the effects on HIV risk practices. So our analytic sample for this study and this analysis I'm going to present today included 249 people who inject drugs, who completed an interviewer-administered survey in January and February of 2019. And this was a convenient sample, and all survey participants were recruited through 4 harm reduction programs in the Toronto area. And our main exposure of interest in this analysis was perceived fentanyl injection frequency. And I want to underscore here that it's perceived illicit fentanyl use, and as such might underrepresent actual illicit fentanyl use, given the highly volatile market and unknown toxicity of drugs. So we looked at perceived fentanyl injection frequency in 3 categories: daily use, a daily injection, less than daily injection, and not injecting fentanyl. Our outcomes were sharing a filter, sharing a cooker, sharing a syringe with someone else. And we also constructed an overall injection risk variable that was sharing of 1 or more of these items with someone else. We then estimated crude and adjusted predicted probabilities from logistic regression of injection-related risks for each subgroup of fentanyl injectors, and used the test of difference for subgroup comparisons based on the frequency of fentanyl injection. And our final models were adjusted for age, gender, recent incarceration, recent homelessness, frequency of heroin injection, frequency of other opioid injection, and frequency of non-opioid injection. So moving to our results, I'm first going to present some descriptive characteristics on our sample. We had, in our sample of 249, 47% of participants reported daily fentanyl injection, 20% less than daily, and 31% did not inject fentanyl. Further looking at racial ethnic identity, 33% of our sample were participants who identified as First Nations, Métis, and or Inuit. 6% identified as Black, 7% identified as other racialized identities, and 55% identified as white. In terms of gender, we had women. Women were 22% of our sample, 46% of our sample identified as men, and 1.6% of our sample identified as non-binary or other. And strikingly, 66% of our sample experienced homelessness in the last 6 months, which is a very high number. Okay, so moving to our results. Here are our fully adjusted predicted probabilities for each outcome. So here in the column for syringe sharing, our model predicted that the percentage of daily fentanyl injectors who shared a syringe was 25% among those who injected daily versus 20% among those who injected less than daily, and 5% or 4.9% among those who injected did not inject fentanyl. In the column for sharing a syringe, our model predicted that the percentage of daily fentanyl injectors, that 42% would share a cooker, 37% among those that injected less than daily, and 11% among those who did not inject fentanyl. And then in the next column, we see very similar predicted probabilities for those who injected daily and less than daily at 30%, who reported that our model predicted would have shared a filter, and just under 10% among those who did not inject fentanyl. And then finally, on our constructed fourth variable of overall injection risk, our model predicted that the percentage of daily fentanyl injectors who shared equipment was 47% compared to 40% among those who injected less than daily, and 16% among those who did not inject fentanyl. Here I have a graph of our model estimates for each type of injection equipment that offers a visual depiction of the pattern of sharing, which was lowest among those who did not inject fentanyl, and higher among those who injected less than daily and daily, which are the gray and the green bars. And importantly, I want to mention here that we computed tests of difference, contrasting the different levels of fentanyl injection to determine whether the increases in sharing were significantly different from each other. And at a significance level of an alpha of 0.05, there were no detected differences in equipment sharing between participants who injected daily and those who injected less than daily. There were, however, significant differences in the probabilities between participants who did not inject fentanyl compared to both groups who injected daily and less than daily. The exception to this pattern was syringe sharing, where there was a difference detected between those who injected daily and those who did not inject at all, but there was not a significant difference detected between those who injected less than daily and those who did not inject at all. Okay, so our key findings in our study, illicit fentanyl was associated with increased sharing of syringes, cookers, and filters. And this is, I'll note here that cookers are the most frequently shared piece of equipment. And this is a finding that is consistent with other studies showing that the cooker is the most commonly shared piece of equipment. Second, we found no differences in the probabilities of injection equipment between participants who injected daily and less than daily. And the absence of this dose response suggests to us in our interpretation that injection risk practices associated with fentanyl may be influenced by other factors, such as access to harm reduction supplies, access to drug sellers, income level, the impacts of criminalization, withdrawal severity related to fentanyl, as well as processes of mutual aid and caretaking among people who use drugs, people who inject drugs. So there are several limitations in our study that I want to, some of which I'm pointing out on this slide. So first of all, the categories of daily and less than daily fentanyl injection may not be, in fact, meaningfully capturing enough variation in injection frequency, which may be why we don't see a difference between the group that injected daily and the group that injected less than daily. Also, our study is cross-sectional, uses cross-sectional data, which precludes the establishment of temporal ordering between fentanyl injection and injection risk practices. It's also a convenient sample, so is not generalizable to people who inject drugs in other settings. And also our smaller sample and the absence of a stratified sampling approach severely limited possibilities for gender-specific analyses in this study, as well as specific analyses of the experiences of Black, Indigenous, and other racialized participants. And this limitation highlights the need for collection of specific data by and for these communities who are very often structurally excluded and minimized in harm reduction research and other research. So our main conclusions and thoughts going forward for further action, illicit fentanyl injection was associated with increased HIV and injection risk practices. To reduce these risks, we need much wider availability of harm reduction supply distribution, including in the shelter system, in places where people live, and in the expansion of satellite type programs to reach people. We also need safer alternatives to the toxic drug supply through safe opioid supply, safer supply programs, and heroin-assisted treatment. And these programs have the potential to address and mitigate some of the other factors like the costs of drugs, the impacts of drug criminalization, as well as frequency of injection. And additionally, there's a need for low barrier services for people who inject drugs to access HIV prophylaxis, as well as HIV and HCV testing, and using multidisciplinary treatment models to work with people who inject drugs. I want to thank my co-authors, Jillian Kola, Debbie Phillips, Sarah Gregg, Molly Betterman, Jason Altenberg, Carol Strike, and Ahmed Bayoumi, who have been vital in the interpretation of this analysis and informing all aspects of the manuscript that we currently have under review. And this study and the broader project that it's part of was possible due to the valuable contribution of many people who have generously shared their thoughts, time, and experience with our team. This includes substantial contributions from people who use drugs, who participated in the survey, as well as members of our community or advisory board. I also want to acknowledge the continuing and devastating impacts of the overdose crisis on community members who participated in this study, including honoring the important contributions of community members who have died of overdoses since we began this project in 2018. And lastly, I want to thank our funders, the Canadian Institute of Health Research and the Canadian Research Initiative on Substance Misuse. Thank you very much for your time. I'm happy to take questions.
Wonderful. Thanks, Kathleen. So we do have quite a few questions, but we are short on time. So we will go through two of those and you can respond to the other questions in the chat. If you go on there, you can see them and you can send the response to the person who asked them. So the first question is, were there any questions asked of the study participants in regard to practices they engaged in to avoid HIV and hepatitis C infection?
We did ask questions about where people were connected to, harm reduction programs and if they worked in harm reduction programs. So that was one way that we got some of that information. Yes.
Okay, thanks. And the second question is, can you discuss in a bit more depth the generalizability of these findings? Do you expect hidden groups of users that would not likely be sampled? And if so, can you discuss the implications of such?
So we recruited our sample from 4 Toronto area harm reduction programs. So it would be, it's specific to the communities that would access those programs. So as far as the availability of supplies, if people are already connected to those programs, we would think that they would have more access to supplies. However, there are still several and many levels of barriers to getting supplies. There's been 4 other studies to date that have looked at this relationship between fentanyl injection and HIV and other injection risk practices, and they have all been in other jurisdictions outside of Canada, where there are not the same level of harm reduction supplies. There aren't safer consumption sites. So certainly there are a lot of limitations in how these findings would be generalizable, but it's also, unique that our sample included a lot of people who are already connected to harm reduction programs.
Wonderful. Thanks a lot, Kathleen. Thanks for those responses. We will move on to our next speaker, who is Alexandra Muston from the Ontario HIV Treatment Network, and she will be talking about GetAKit, applying complex adaptive system theory to HIV self-testing expansion in Ontario. Alexandra, you have the floor.
Thank you. Okay. Are you guys seeing the full slide or my notes?
Great.
Yes, okay. Hi, so I actually, as of Monday, have switched from the OHTN to the University of Ottawa. So I am now the Director of GetAKit implementation at the University of Ottawa. My slides are going ahead of me. Hang on a second. Okay, so just a bit of background about GetAKit. It's funded by the OHTN, run by U of O, and it is a study to evaluate the feasibility and acceptability of mail-out HIV self-testing. We launched in Ottawa July 20th of 2020, so a few months ahead of Health Canada's approval of the device. And we launched our first sub-site in, I don't know why my slides want to go forward. Sorry, we launched our first sub-site in Toronto in April of 2021. And it just so happens that we launched our most recent site last April. So over the last 12 months, we've been able to implement the GetAKit program pilot in 20 sites across the province. So I wanted to share a couple of ideas and definitions before we get into how we've applied it to the implementation. Complex adaptive systems theory really works well for our approach as a framework because it talks about how it's a group of interacting and interconnected elements that form a complex whole. And so really when we were looking at expansion, we saw every region and their individual or like their local HIV care cascade as one system and all of the elements within that as part of that system, and then slowly start to expand that until you have a bunch of different systems that are working together at the province level. And then of course, this will have unpredictable outcomes. So the amount of different stakeholders and actors and folks that are interacting when you're just talking about HIV testing alone is more than I think any one of us really can list quickly. And we don't always know how those relationships work together. And we know that it's different depending on the region. So then the next concept that I am particularly invested in, I'm just gonna see if I can pause these. There we go. Going to stop moving ahead of me. So the next idea that I find really fascinating and I think really applies to this is the concept of self-organization. And I rely really heavily on Donella Meadows' definition of it. So she says that it's the capacity of a system to make its own structure more complex. It'll produce heterogeneity and unpredictability, and it requires freedom and experimentation and a certain amount of disorder. So when you think about complex adaptive systems and you think about this idea of self-organization, together, when we're talking about making a pilot or making something applicable in the place where it may not have been originally piloted, we want to start asking questions like, how do we identify examples of self-organization? How do we encourage it? Meadows also talks about how self-organization is an organic thing. It's not something that you can just assign or ask somebody to do. It's something that sort of comes of its own. And and then we wanted to also ask how we could control for the unpredictability factor. It's just weird because I never have my stuff forward on its own. Okay, hopefully this stops it. Sorry. Right, so control in this context isn't like holding the reins, but it's more about how can we be flexible in the face of it. Okay, so to answer those questions, we asked more questions. So every time we approached a site for implementation, we had the same kind of discussion with every new partner. So we started with, of course, how are you? We were launching in COVID. There were a lot of different changes. We weren't sure if folks were working in the office, or if they were remote, if they'd had a huge staff turnover. Like, we kind of wanted to get a sense of agency readiness. And then next we talked about adaptations they may have made for remote outreach to their clients. And this was because we knew going in Get a Kit is an online ordering system at its like core. So like the highest registration barrier access is high barrier. So you have to have a computer, your Wi-Fi, be okay with the kit coming to your house. And we knew that would only work for a certain number of folks. So if there were agencies that were managing with or doing outreach with people who we knew already couldn't access that barrier, it would be really helpful for us to know how they were reaching out and talking to them. The third bullet was the one we unpacked quite a bit. So previous experience offering HIV point of care testing in their area. This is where we were trying to tease out in those conversations, those examples of self-organization. What partnerships did you create? What pop-up clinics did you participate in? What was your role in the pop-up clinic? Was it a pre or in the post-test counseling? Did you help with linkage to care? How are those partnerships now? What were the barriers that the clients at the time told you about? Were they comfortable with the device? Because the point of care device and the self-testing device are identical, except for the pipette. So these were where we wanted to try and capture as much information as we could so that we would understand going in what the existing challenges were and what the solutions would have been if they had come up with solutions, and integrate that as part of offering Get a Kit in the area. And then we finished off the conversation with just ensuring that they had clear connections with a clinic that could do the confirmatory HIV testing and offer PrEP assessment as well, so that Get a Kit linkage to care could be status neutral. So then from those conversations, we also were able to come up with some really clear definitions of roles and responsibilities between the core Ottawa team and the hub sites. And it's that urban myth that I think it's an urban myth where the city planner doesn't put down the sidewalks and they wait until the grass is patted down with natural migration and then puts the sidewalks over top. So that's kind of the analogy that we were using. Like, we wanted to see what paths had already been pre-established and sort of weathered, and then we would try to fit Get a Kit on top of that and not beside it. And really what it ended up being was the core Ottawa team would take the responsibility of the eligibility and self-assessment questions because they're basic clinical practice, and then really everything that had to do with the study in addition to that. So like the storage of the kits, quality control and assurance, the shipping and logistics, the training, the website maintenance. And this left it for the hub sites to just do what they've been doing all the time, which is the regional communications and outreach. And then they would take on the monitoring of the dashboard for local participants to initiate follow-up, and then also be responsible for internal communication to help with other processes like curbside and manager mode. So once the site had launched, we check in monthly just to get a kind of routine process for feedback, all kinds of feedback. So sometimes we would get, we delivered like 10 kits, so we reached out to these participants, and then sometimes we would get feedback that's like, this isn't working. So we really wanted to just protect some time monthly to go through both of those things. And sometimes if it was tech issues, then we could troubleshoot in real time, or we could get help from some of the nurses, the nursing team in the core Ottawa group as well. We really try to be as available as possible when things kind of pop up. And then of course, there's common issues coming up at all sites, we'll try and figure out like a system response for it. And the main challenges that came up were the three that I've listed here. Registration barriers, again, we kind of went in knowing that we would have to build in lower access registration pathways for folks. So we, in talking to the sites, developed the curbside pickup. So it's kind of like getting curbside for your groceries, or if you're buying a book or something. And then on-site registration, which is where the individual goes to the site, there's a dedicated device the person uses to register in manager mode. And so every time that we lower the barrier for participants, we're just increasing the administrative responsibility of the site. So there's training and supports, and always troubleshooting when we launch those. As well, we talked about language barriers. So Get a Kit was originally launched in French and English, but it's available in Spanish and simplified Chinese. And then staff turnover. This is a really big one. I think staff turnover is a really common thing, and we're also in the, I think we're in the midst of the big resignation, the grand resignation. There's a lot of turnover. So we address it first by providing ongoing training, making sure our user guides are up to date. We create little cheat sheets for folks who are newly onboarded. Just recently, I know what the problem is now and I don't know how to fix it. Sorry about my slides. Just recently, we've been offering centralized follow-up just to kind of take the pressure off of sites to check the dashboard daily, so that they can focus on their HR requirements. Okay, so the results. Uptake since we launched in July of 2020 has been around a little over 2,500 kits. The bulk of that has occurred during the period of our expansion. Our eligibility rate is around 73%, which is really good. The reasons for ineligibility could be that you're testing too frequently, you really don't have any risk for HIV, or you're trying to access it from outside of the province. Get a Kit's currently only accessible in Ontario. We also are recruiting, or participants are self-identifying as being a member of Ontario's HIV priority populations. And we're finding that actually a third of participants are also first-time testers, so that's very encouraging. We're maintaining around a 61% report rate, so that means that people are ordering the test, doing it, going back to the website and putting in their result. Our positivity rate for all tests, so that's all of the kits that go out, is 0.36%. And for those who are reporting results, it's just under 0.7, and those are comparable to the Ontario testing as well. If you're looking at the invalid percent of 19 and think that that's pretty high, we agree. So we just recently had an article published in the JANIC journal about the invalid results being reported in the Get a Kit system, and some of the strategies that we've implemented to overcome them. So I will wrap this up with two lessons learned, or two thoughts, I guess, using the approach, this sort of CAS systems thinking, complexity thinking approach to implementation, I think has been a tremendous benefit. Our first launch took about 5 months, and we're very grateful to our partner, our first hub site, for their patience. But then afterwards, this meant that we could turn around a site in as little as 3 to 4 weeks. And then the last part is that we know that there is no one-size-fits-all model, but there are core pillars to offering HIV testing and local experience, and Get a Kit, I think, really optimizes those two things. We rely on current federal and provincial HIV testing guidelines, and we learned a lot from existing local experience around self-organization of point-of-care testing to deliver a program across the province. I am between emails right now, but if you have any questions or if you want to follow up with anything, you can reach out to Patrick O'Byrne, who's the principal investigator, or Jennifer Lindsay, who is our coordinator. Thank you.
Wonderful. Thanks, Alexandra. We have time for one, maybe two questions. Is there a correlation between the idea of self-organization and privatization of services? If so, is that considered a negative outcome?
So between self-organization and the privatization of services, I don't know. I mean, I do feel like I'm a bit out of my league on this panel because there's so much great analysis of data. I think self-organization, like Meadows says, that self-organization in the relationship with government is sort of tricky. And I think the higher up you get and the more regimented the request for self-organization becomes, the less it is. You know, I think it's grassroots. It's very organic. So I don't know if privatization necessarily nullifies it, but it's not really what I've been exposed to or looked at. It's a great question though.
Okay, wonderful. And there's a second one, was having OHIP and eligibility criteria for this work?
No, which is great. Like OHIP isn't a requirement to do the HIV self-test, but OHIP would come into play later on, I think, like if it occurs during linkage to care. But we've also, there are a lot of really great partners who have services and programs to support folks who don't have OHIP coverage. So we took that into consideration.
Wonderful. Thanks, Alexandra. That was an excellent presentation. We are just in time to move on to our next speaker, Ireneus Konkor, who will talk about access to healthcare and the burden of sexually transmitted infections among heterosexual African, Caribbean, and Black men in Toronto, Canada. Ireneus, you have the floor.
Yeah, thank you, and good afternoon to everyone. My name is Ireneus, and my presentation is on access to healthcare. Yes. Yeah, so my presentation is on access to healthcare and the burden of sexually transmitted infections among heterosexual African, Caribbean, and Black men in Toronto, Canada. So for this presentation, this will be the outline. So we'll look at the background and some data, results, and then discussion. Sexual health reports in Canada continue to show increasing trends of sexually transmitted infections. And evidence from one of such reports show that syphilis, for instance, rate of infection doubled between 2003 and 2012. And that was an increase from 2.9 per 100,000 people to 5.8 per 100,000 people. Over this period, the rate of infection actually decreased by 40.9% among women, but then it actually increased by 128.3% among men. In a similar study, gonorrhea, that focused on gonorrhea, for instance, prevalence rate was found to be as high as 55% per 100,000 people, and the number of new cases increased by 65.4% between 2010 and 2015. What is even more worrying is that the rate of gonorrhea infection actually increased by 85.2% among men, and among women, it increased by 39.5% between 2010 and 2015. Even though these figures may appear generally unacceptable, especially in the case of Canada, chlamydia is even the most reported STI case in Canada. And in 2015, for instance, chlamydia prevalence was as high as 325 per 100,000 people. And even though the rate of increase was higher among women, it was actually, the rate of increase was higher among, the rate of new increases were actually higher among women, and that is among men, and that is actually 38.5 versus 9.3% between 2010 and then 2015. So the increasing cases of STIs present a major clinical concern, and especially among people who have been, or populations that have been burdened with certain STI cases, especially HIV, among marginalized and racialized populations in Canada. And this is because STIs, sexually transmitted infections, are able to alter the immune system of people who have been infected. And what this means is that actually increases the risk of co-infection with many other STIs, such as HIV in particular. Previous studies have theorized at least two important biological interactions between HIV and other STIs. And the first is that among people who have been co-infected with HIV and any other STI, those HIV viral loads are always higher in the blood and genital secretions of this particular population. The second connection is that among people who have been co-infected with HIV and any other STI, there's always a higher density of HIV susceptible cells in the genital tissues of people who have been co-infected. As a matter of fact, the evidence even suggests that STIs are able to break protective mucosal barriers and then recruit susceptible immune cells such as the CD4 T helper cells and macrophages to sites of infection. And the implication here is that people who have HIV have higher risk of transmitting it to their sexual partners. When you take gonorrhea, for instance, it is found to increase HIV viral load in people who have been co-infected with it by 0.7 copies per milliliter to log base 10. And the estimate is that 1.0 copies per milliliter to log base 10 can actually double the risk of HIV transmission between sexual partners. And what is even more important is that people who have been co-infected with these sexual transmitted infections often tend to have complications with the diagnosis of the individual cases. And the problem here is that it actually confounds the treatment process, which makes it difficult for treatment, even though many known STIs are curable these days. So the evidence presented so far suggests that there is the need for timely diagnosis and effective use of health services, and especially if you want to curtail the spread of STIs. And this is even more important among racialized and marginalized populations who often tend to have access barriers to healthcare and resources. So for this study, the objective was to examine the patterns of access to STI health services among a sample of heterosexual African, Caribbean, and Black men in Toronto. And we focus on this particular population because African, Caribbean, and Black people are disproportionately burdened with STIs such as HIV in Canada. And that notwithstanding, little is known about their access to and use of STI-related health services. The few studies that have examined this relationship often tend to focus on the individual STI cases, and especially HIV. So to achieve our research objective, we use data from the quantitative phase of a community-based study that was implemented in Ontario called We Speak between 2015 and 2020. The data for the quantitative phase was collected between March 2018 and February 2019. For people to qualify, for the recruitment and sampling strategies, we use conveniences and snowballing sampling strategies, and respondents were recruited from venues such as coffee and barber shops, university and college campuses, community centers, and religious organizations. We also recruited some of the participants from programs that were organized for and by the Black communities, such as health fairs that were organized for them, the Black History Month events, and then sports activities. We also designed and advertised the projects with contact details for people who were interested to reach out to us for recruitment. In all, we were able to reach out to 325 individuals in Toronto, and 240 were able to complete the survey for this particular analysis. For people to be qualified to participate in this particular study, they first needed to self-identify as a heterosexual, African, Caribbean, and a Black man. They needed to be 16 years or older at the time of the survey, and they should have been able to speak either English or French because the survey was designed in those two languages. They also had to be residents of Toronto to be able to participate in the study. For the analytic strategy, we fitted complementary log regression models to the 240 individuals who completed the survey. And with the dependent variable being access to healthcare, last respondents were asked about the challenges they encounter, whether they encountered any challenge accessing healthcare in the past 12 months. The main independent variable was STI status. So we asked respondents whether they had previously been diagnosed with a number of STIs, such as syphilis, gonorrhea, Hpv, and then chlamydia. In the analysis, we accounted for other theoretical relevant variables, such as whether respondents had a family physician, and whether they had difficulty meeting the basic needs, such as food and language, in particular, whether they were fluent with the English language or not. So the results suggest that about 18.3% of the sample had a history of one or more STI diagnoses. And the most common STIs were HIV, which accounted for 6.6% of the sample, and then chlamydia, which accounted for 7.7% of the sample. Among the participants, some of them indicated they had difficulty accessing healthcare in the 12 months prior to the study. And among this group of people, 7.7%, that is this particular figure, 7.7%, in 7.7% of the participants who said they had difficulty accessing healthcare actually had histories of multiple STI cases. That's more than 2 cases. And 23.1% indicated who indicated they had access problems with the healthcare had a history of 1 STI case. For the multivariate analysis, the results show that heterosexual Black men with histories of multiple STIs were about 2 times more likely to report having trouble accessing healthcare in the 12-month prior study compared with those who never had any STI in their life. Respondents without family physicians were also more likely, that's about 1.8 times more likely to report difficulty accessing healthcare compared to those who indicated having family physicians. Other structural factors such as unstable housing and people who also indicated they had difficulty meeting the basic, daily basic needs such as food were significantly more likely to indicate having problem accessing healthcare in the previous 12 months. When we interacted language fluency and then STI status, what we found was that people who were not fluent with the English language were also more likely to indicate having problem accessing healthcare the 12-month prior study. So what does the results say in plain language? What we have found in summary is that heterosexual African, Caribbean, and Black men who had histories of STIs were more likely or had trouble accessing healthcare in trauma. And this is largely due to the systematic and discriminatory experiences they have encountered within the Canadian setting. Black sexuality, for instance, has been blamed problematically both within the healthcare system and the media, where Black people are often described as aggressors in sexual relationships and people who are generally disinterested in their own health. Our findings further suggest that the factors that Black men, the problems that Black men face accessing healthcare are many and also interacting. And this is because language fluency in itself was not a significant predictor of difficulty accessing healthcare until we interacted language and then STI status. And what this means is that the programs and policies that are designed for curtailing the spread of STIs need to be designed with an intersectionality lens to be able to capture the many facets that impact access to healthcare within marginalized population and especially the Black community. Thank you very much. I would like to acknowledge the CAHR and then the OHTN who funded this particular study. And then thank you all for listening to this presentation. I'll now be happy to take any questions. For those who are interested in further readings, these are some citations.
Wonderful. Thanks, Irenia. So there's one question in the chat for you from Anne Burchell. How was trouble accessing healthcare defined?
So the question on the question in the survey was have you had any difficulty accessing healthcare in the past 12 months? So that was the question that we asked. And I must also say that the survey or the study in itself was implemented in phases. So it's a larger project that was implemented over a 5-year period. So the first 2 phases were qualitative. So the survey that we designed was informed by responses from the 2 previous phases. So based on the responses of the respondents in the qualitative phases, then we designed the questions, and that was how we had this particular question in the survey.
Okay, wonderful. Thanks, Irenaeus. We will move on to the next speaker, who is Kathleen Chambers from the University of Toronto, and she will be talking about low human papillomavirus vaccine coverage among women living with HIV in Ontario. Kathleen?
Great, thank you. Can you see my slides okay?
Yes.
Wonderful, thanks. So as Lawrence mentioned, I'm going to be speaking today about human papillomavirus vaccine coverage among living with HIV in Ontario. And I'm presenting these results today on behalf of my co-authors who are listed here. So human papillomavirus, or HPV, is an important co-infection among women living with HIV. And that's because women who are living with HIV are at higher risk for cervical and other HPV-related cancers. For this reason, our national guidelines do recommend that women who are living with HIV should be vaccinated against HPV. Since 2006, this vaccine has been authorized for females up to age 26 in Canada. And since 2011, this age indication has expanded up to age 45 years. Several provinces in Canada do offer free HPV vaccine for women who are living with HIV. However, I should note that in the province of Ontario, where we've done this study, women are not currently eligible for free vaccine if they're living with HIV. HPV vaccine is a very expensive vaccine. It can cost up to or over $100 per dose. And for people who are living with HIV, it's recommended that they receive all 3 doses, regardless of their immune status. So previously, my colleagues had looked at HPV vaccine uptake among men who are participating in the Ontario HIV Treatment Network cohort study. And in that analysis, they found that uptake was quite low. So only 7% of the men living with HIV in the OHTN cohort had been vaccinated against HPV. For this analysis, we wanted to repeat that assessment, but to look at women who are attending HIV care in Ontario. As a secondary objective, we sought to identify the sociodemographic, behavioral, and clinical characteristics that were associated with HPV vaccination. So for those of you who are unfamiliar with the OHTN cohort study, or the OCS, it is a multi-site clinical HIV cohort in Ontario. In order to be eligible for this cohort, you have to be at least 16 years of age, have a laboratory confirmed HIV infection, be attending one of 15 participating clinics that provide HIV care, and provide written informed consent. For the purposes of this analysis, we decided to focus just on those individuals who identified as either a cis or trans women, because as I mentioned, the analysis among men participating in the cohort had already been completed. The OCS obtains data from multiple different sources. These include medical chart abstraction and linkage to laboratory data. Participants also undergo an annual interview-administered questionnaire. As part of this questionnaire, we implemented a one-time cross-sectional module between 2017 and 2020. Participants were asked questions about HPV vaccine knowledge and receipts. We additionally asked questions more generally about HPV knowledge, as well as cervical cancer screening, and those results would be presented by some of my colleagues at different sessions in this conference. So the outcome for our analysis was looking at self-reported HPV vaccine uptake. We defined this in 2 ways. First, we looked at vaccine initiation, so whether or not women reported receiving at least 1 dose of the HPV vaccine compared to unvaccinated women. We then looked at completion of the 3-dose series compared to women who are either unvaccinated or who had received less than the 3-dose series. We used logistic regression in order to derive age-adjusted odds ratios and 95% confidence intervals. Overall, we had about 600 women who participated in the HPV module and who had complete information available on HPV vaccination status. Overall, the median age of our participants was 48 years. And I'd like to emphasize the older age of this cohort, in particular being older than the current age authorization for HPV vaccine in Canada. 98% of our participants were biological female at birth. Over half identified as being Black, African, or Caribbean, and 5% identified as being Indigenous. We also had a very large proportion of immigrants in this sample. About 2/3 of our participants were immigrants, and in particular, 58% reported being immigrants from countries where HIV continues to be endemic. About 1/3 of our participants had been living with HIV for more than 20 years, again, likely reflecting the older age of this cohort. And almost all of our participants were on antiretroviral therapy and had suppressed viral loads. So overall, about 2/3 of the women had heard of the HPV vaccine in our sample, and 13% reported being vaccinated with at least one dose of the HPV vaccine. Among those women who were vaccinated, most, or about 65%, had received all 3 of their recommended doses, with the remainder receiving either 1 or 2 doses. The median age at first dose was around 40 years. So here I'm showing the differences in uptake by age group. 10-year age group is shown on the x-axis. On the blue bars, I'm indicating the vaccine initiation outcome. So this is receipt of at least 1 dose of vaccine. And in the orange bars is where we're looking at completion of the 3-dose series. Overall, you can see that vaccine uptake was quite low. Even among the youngest women between the ages of 20 to 29, only about 30% had indicated they had received at least 1 dose. Among women between the ages of 30 to 49, this dropped down to about 15%. And among women over the age of 50, uptake was below 10%. And again, averaging across all of these age groups, overall our uptake was around 13%. So here I'm showing the results for a logistic regression analysis. I'm focusing just on the vaccine initiation or uptake of at least 1 dose. In the interest of time, I won't be sharing the results of the series completion, but the factors that we identified were quite similar to this analysis. So after adjusting for age, we found that vaccine uptake was higher among women who were employed, had higher incomes, were either married or common law, were living with children in the household, had immigrated to Canada more than 5 years ago, were non-smokers, and had spent longer time in HIV care. We also had the opportunity to look at the associations between HPV vaccination and general knowledge, attitudes, and beliefs about HPV. So we found that vaccinated women were more likely to report that they were familiar with HPV or knew a lot about HPV. They also were more likely to believe that only women can get HPV, which is false. Both men and women can get infected with HPV. But other than this characteristic, vaccinated and unvaccinated women didn't seem to differ on any of the other HPV knowledge-related questions we included on the survey. There was also a trend for vaccinated women to report a history of having an HPV-associated disease like anal warts or precancerous lesions. However, I should emphasize that these are cross-sectional data, and so we don't know the timing of when women were vaccinated relative to when they were diagnosed with HPV-associated disease. There's a few limitations to acknowledge. Again, this is a cross-sectional survey. We are using self-reported vaccination status, and we're unable to validate this against any registry or administrative databases. I do also want to emphasize that this is a voluntary cohort of women who are actively engaged in their HIV care. And for this reason, we believe that we've likely overestimated HPV vaccine uptake in this population, despite our overall low vaccine uptake rates. I again also want to emphasize that the cohort is older than the recommended age for HPV vaccination currently in Canada, and has a large proportion of immigrants who may have had limited access to the HPV vaccine in their countries of origin. So overall, again, we found that HPV vaccine coverage was low at around 13%, and this is well below the WHO target of 90% as part of their cervical cancer elimination goals. Even among younger women who we feel are most likely to benefit from vaccination, uptake was below this target at around 30%. Based on these findings, we recommend mechanisms for improving uptake, and this might include educating healthcare providers as well as advocating for public funding of HPV vaccine for women who are living with HIV in the province of Ontario. And with that, I'd just like to acknowledge the many committees that contribute to the OCS. Thank you.
Thanks, Catherine, for an excellent and informative presentation and for completing it in 10 minutes. I see some questions in the chat here, and I will go ahead and read them out to you. As a measure of comparison, what is the coverage of HPV vaccination among people living with HIV in provinces where the vaccination is covered for people living with HIV?
That's a really good question. I actually don't have that data for women. In fact, there's been very, very few coverage surveys of HPV vaccine among women who are living with HIV. I do also do some work with the Engage study, which is a cohort of gay, bisexual, and other men who have sex with men in Vancouver, Toronto, and Montreal. So in those cities, we don't find much difference in terms of vaccine uptake. It does tend to be much lower in Montreal relative to Vancouver and Toronto. But in those provinces, they do also have free vaccine available for gay, bisexual, and other men who have sex with men. So it's harder for us to tease apart the differences between identifying with that group versus a person living with HIV. But in general, we do find that the vaccine uptake is higher in provinces that do offer publicly funded programs for these high-risk groups.
Okay, wonderful, thank you. You did mention lapses in knowledge with regards to HPV vaccine, which is affecting the uptake. And you mentioned the need for some form of capacity building or education for health providers and for women living with HIV as well. What are your thoughts about how to implement this education either among health workers or among women living with HIV?
I mean, I think that's an excellent question. And I think the first step is engaging members of the community to find out, what is the best method for reaching these communities for trying to improve vaccine uptake. I mean, we're suggesting that we improve education of our healthcare providers. We know that the women who are participating in the OH10 cohort study are actively engaged in their HIV care. So automatically, we've got an entry point to be educating the healthcare providers who are regularly seeing these women and can promote HPV vaccination as part of their routine HIV care visits or as part of their general health assessments through family physicians, for example, at PAP screening visits, et cetera. And then in terms of reaching the community, as I've mentioned, I think it would be really important to have a community-driven approach. And we do have members of the community who are living with HIV participating in this study and are actively involved in knowledge translation of these findings back to those groups.
Wonderful. Thanks a lot, Catherine. We will move on to our next speaker, who is Daniel Grace, presenting from the University of Toronto, and he will talk about the challenges to communicating the undetectable is equal to untransmittable HIV prevention message, healthcare provider perspectives. Daniel?
Great, thanks so much, Lawrence. Good afternoon, and thanks to the CAHR organizers for the opportunity to present today. I'd also like to thank my co-authors on this paper that's currently under review. Since 2015, many HIV prevention and stigma reduction campaigns have been disseminated internationally that communicate the message that undetectable equals untransmittable, or U equals U. Over the past 7 years, the HIV stigma reducing, as well as the scientific implications of HIV undetectability, have been incorporated into public health community messaging through the concise discursive framing of U equals U. Multiple Canadian studies, including some of our previous work, has demonstrated that gay, bisexual, and other men who have sex with men have become increasingly exposed to U equals U messaging. Surveys of Canadian GBM indicate that experiencing social marginalization has a significant negative impact on the diffusion and uptake of the U equals U message. Qualitative research has also observed significant untransmittable skepticism by some GBM who are resistant to the U equals U framing and who describe hesitancy and fear associated with having condomless sex with someone living with HIV, even if they have an undetectable viral load. And beyond GBM communities, research has indicated that heterosexual adults, including Black and Latinx people, have lower awareness of the U equals U messaging or lower confidence in U equals U. According to the Prevention Access Campaign, as of April this year, 1,068 organizations from across 105 countries have signed on to share the U equals U message. This is an interactive map on their website to help see the jurisdictional and organizational reach of this message. Researchers have argued that the U equals U message should be routinely communicated to all patients living with HIV. Calls have also been made for universal patient-provider education regarding U equals U, regardless of serostatus. However, a number of recent studies have pointed to challenges when communicating this message, including a lack of provider training and education on the concept, as well as limited staff resources in some contexts. In other studies, providers have noted that they didn't want patients to see U equals U as a way to replace other prevention methods, such as condoms, that could also aid in STI prevention, as well as birth control. Some providers have also described their concern of being responsible if HIV transmission were to happen after providing U equals U education to their patients. Given these various concerns and an uneven adoption of U equals U internationally, our objective was to better understand how various STBBI service providers communicate the U equals U message to sexual health users, service users in Ontario. We were specifically interested in trying to understand the communication of the U equals U message in everyday practice, including the barriers experienced by service providers who convey this HIV prevention message. We used a community-based participatory research framework to guide our study activities. For peer researchers who self-identified as part of the 2S LGBTQ+ community were engaged in all aspects of the qualitative study design, including leading interviews and helping to code, interpret, and synthesize study findings. The qualitative research with service providers that we present in this paper occurred in the context of a larger mixed method study investigating the use and adoption of online STBBI testing services in British Columbia and Ontario. We conducted online semi-structured focus groups and interviews with 18 service providers of STBBI testing and other sexual health services in Ontario. Participants were asked questions about sexual health communication, including U equals U messaging, and individual interviews and focus groups were audio recorded and transcribed verbatim following grounded theory techniques. Our 18 participants had a wide range of career experiences, including frontline workers at community-based HIV service organizations, sexual health nurses, physicians, and public health workers. Our participants primarily practiced in the Greater Toronto Area, Ottawa, and other large major urban areas in Ontario. And providers primarily said that they worked with clients who were GBM, people who used intravenous drugs, and people who were trans or gender nonconforming. The majority of service providers we spoke to explained that the U equals U message was a useful way to communicate the science of HIV prevention. Many participants described how U equals U as a mantra was part of their regular script or their regular spiel that they gave to people when testing in sexual health clinics. Providers also noted how they drew on scientific research findings to help communicate the science and the significance of U equals U. We can see this in the quote from one sexual health nurse here. This nurse explained the science behind the U equals U message was new to many of the service users they interacted with. Some providers also emphasized how U equals U was, quote, part of the menu of options, and discussed it in relation to other forms of biomedical HIV prevention, noting that PrEP, PEP, and condoms were still very much still on the quote unquote menu of HIV prevention. While a few sexual health nurses said they didn't experience any major difficulties communicating information on undetectability, most providers we interviewed encountered one or more challenges when communicating the message. I'll now review the 4 interrelated challenges our participants discussed. A few service providers emphasized the limitations to the U equals U message, noting that treatment and an undetectable viral load does not result in HIV untransmissibility, quote, 100% of the time. One public health worker with extensive clinical nursing team experience described resistance and caution when communicating the message that, quote, zero risk exists, which you can see in this first quote here. A frontline worker explained needing to, quote, leave a margin for U equals U not being effective. They drew on experience volunteering at an ASO and providing support for people living with HIV. However, this service provider went on to explain how they frequently drew on embodied experience as someone living with HIV when talking about U equals U and the importance of HIV treatment. Quote, I am proof that it, U equals U, works. Many of the participants we interviewed emphasized the importance of delivering sexual health information based on the needs and desires of service users. This was frequently framed as client-centered care and led providers to deprioritize conversations about U equals U. In some cases, providers said that they delayed conversations about U equals U after a diagnosis with HIV in order to avoid, quote, information overload for people and contextualize this information as part of a larger subsequent discussion. Some providers said that they delayed discussions about U equals U with service users, relaying the message only in very specific circumstances, saying that they needed to, quote, focus on client-centered care. Some service providers discussed the mistrust or skepticism with U equals U they encountered among service users, including but not limited to GBM service users, and reflected on how persistent HIV stigma may shape service users' understanding and acceptance of this HIV prevention message. For example, one STBBI testing professional explained how, quote, HIV stigma and all the fear that people have around HIV resulted in service users being fearful of HIV transmission occurring in sexual encounters without the significant possibility of HIV transmission, such as oral sex. A volunteer at an AIDS service organization explained U equals U hesitancy and drew upon Katie messaging in their framing of the, quote, third U, universal. Quote, I think even some people would be hesitant to believe that U equals U is true because of the stigma attached to it and everything that goes along with it, this person said. In short, while this is framed as a stigma-reducing marketing of the science, HIV-related stigma is a barrier to the uptake and communication of the message. The service providers we interviewed also mentioned a diverse range of U equals U resources that they offered to service users. I've listed a number of these resources here, including those made in-house, like posters and pamphlets. The GMSH's The Sex You Want campaign was frequently described as an incredibly valuable, sex-positive, and dynamic source of accessible messaging on U equals U and the meaning of HIV undetectability. A few participants, however, noted needing more accessible sex-positive resources for other communities beyond GBM. The issue of having U equals U messages available in languages other than English and French also emerged as an area where more resources are required. Our findings echo recent research that describes the inconsistency or lack of clarity with which some providers discuss U equals U and HIV transmission risk, including those who avoid no or zero risk language in favor of negligible or extremely low framings. Studies have shown most care providers recommend condom usage for clients living with HIV. It's not clear from the published literature if providers are always making these recommendations in relation to HIV prevention specifically or STI prevention more generally, and importantly, how service users are interpreting this condom use message. Given the inconsistency of messaging from service providers, it's perhaps not surprising that some sexual health service users in the Canadian context adopt similar negligible risk framings. In efforts to provide client-centered care, service providers said U equals U was not always discussed. Our findings reveal a somewhat tailored approach to discussing U equals U with some patients and not others. Some of our participants described the skepticism they encountered regarding the U equals U message and the stigma encountered from service users. These providers explained how the hesitancy of some service users accepting the U equals U message was shaped by a legacy of HIV risk messages and persistent HIV stigma. Reiner Tan and colleagues have warned about the unintended harms and stigma that may result from the uncritical celebration and promotion of U equals U messages. Quote, uncritical advocacy of U equals U messaging is unwise without close scrutiny from ethics and public health standpoints of how the message is promulgated and received. If U equals U messaging misfires to deepen divides between HIV negative and HIV positive individuals, or is interpreted as a means of parsing out infectious people with HIV from those who have, quote, achieved undetectability and uninfectiousness, then U equals U messaging will have undermined hard-won advances in HIV care, end quote. These concerns of U equals U framings echo warnings of the creation of an undetectable divide between groups and an increase in stigma, a true paradox given the stigma-reducing intention of the messaging. As Katie has highlighted, our collective celebration of U equals U is undermined if access to testing, treatment, care, and support, and viral suppression is not universal. And to be clear, access is not equal, as presentations at this year's CAHR have clearly underscored, including talks this year that have made explicit how U equals U does not work as a discursive frame or lived reality for many Black communities. Further research is required to understand the challenge of other service providers that they face across Canada, including those working with communities beyond GBM. It's important not to let U equals U as a popular discursive frame overshadow this context-specific work and the need to support providers who are working to find the appropriate balance, but might be reluctant to speak about their challenges for fear of being perceived as unaccepting of U equals U and reproducing HIV stigma. We need to speak frankly about these challenges. We should acknowledge the complexity of this important shift in orthodoxy in HIV prevention and offer opportunities for providers to navigate the health communication complexities and ethics so that they're best equipped to translate evidence-based messaging in the most impactful way for service users. And to conclude, no discursive or health communication shift will be meaningful unless structural and material changes are made to ensure comprehensive healthcare and social support is equally available to all. Thank you. And I'd just like to end by thanking my co-authors and our funders, CAHR, as well as our participants. Thanks very much.
Thanks, Daniel. It was refreshing to see some qualitative research in this EPI track. We haven't had much of that, so it was good to see. Daniel, are you still with us?
Yes, I am.
Okay, wonderful. So the first question is, did you see any difference in adoption and communication of U equals U depending on whether most served clients were GBM or heterosexual?
I'm sorry, it was could you just repeat the last part of that?
Did you see any difference in the adoption and communication of U equals U depending on whether the clients were GBM or heterosexual?
Yeah, thanks, Lawrence. Yeah, one of the main things that people spoke to was just there was more resources available that were tailored to communicate the message to gay, bi, queer, and other men who have sex with men communities. So there was a larger toolbox to talk and use culturally appropriate messages. People didn't talk about a difference in the science generally, but mainly about the community messages that they had at their disposal to be able to reference. We're looking and hoping to do more research, because this was an initial sample of 18 service providers, but I think significantly more research is needed to understand how diverse healthcare providers, including those who are not working with gay, bi, queer communities, are knowledgeable and how they're communicating the message.
Okay, wonderful, thanks. Miranda, are you ready? If not, we can take the second question. Do you think provider hesitancy is due to fear of legal consequences in case of seroconversion?
Yeah, it's an interesting question. This was not stated as a significant concern in our data, but there are a number of studies which speak to this, which I think from my read of the existing literature speaks to a lack of provider knowledge in terms of HIV untransmissibility. So some literature does speak to this, this concern of responsibility, quote unquote, being tied to concerns of legal responsibility. So I think we can't speak to that in this context, but I do think it's a relevant question in talking and communicating the science of HIV undetectability to providers and general care practitioners who may be less knowledgeable about HIV science. So in sum, I think the specter of HIV criminalization is really important to consider as a persistent, pernicious barrier to communicating HIV science, as well as furthering HIV stigma.
Okay, wonderful. Thanks, Danielle. We will move on to our next speaker, who is none other than Miranda Kiwatin from the University of Saskatchewan, and she'll be talking about Indigenous Women's Cultural Safe Harm Reduction Model, COTAWE, Starting a Fire, Igniting Cultural Responsiveness Through Community-Determined Intervention Research, sharing COTAWE's preliminary research journey.
Okay, so me and Carolyn are sharing a presentation today, and our presentation is titled Indigenous Women and Cultural Safe Harm Reduction Model, COTAWE, Igniting Cultural Responsiveness Through Community-Determined Intervention Research, sharing COTAWE's preliminary research journey. First and foremost, we like to acknowledge the Indigenous people in the traditional territory where we're presenting today, which is Treaty 4 territory, and it is the territory of the Cree, the Saulteaux, Dakota, Lakota, and Nakota, and it is also the homeland of the Métis Nations. And if you want any more information in whose land or traditional lands that we are living in, there's a site here that I've provided below. This research focuses on Indigenous women from Saskatchewan and is about integrating wisdom from a variety of recently last 10 years completed research projects that focused on various aspects of HIV risk and prevention. This research is about intersectionality in Indigenous women's lives and how communities and systems can better work together with women and one another to deliver better, sustainable, and affordable integrated care. Harm reduction is a complex and value ladder and phrase most often associated with the public health approaches that are designed to minimize negative consequences related to using psychoactive substances, including alcohol and other drugs. Rooted in Western principles of policy, human values focus on harms, balancing costs and benefits, and a priority of immediate goals. 32 previous disparate practices such as needle exchanges, methadone, maintenance program emerged in Canada and initially of the harm reduction or harm minimization practices in the late 80s and 1990s. In response in the case of HIV and AIDS diagnosed among people who were using or people who used injected drugs. Indigenous Women's Cultural Safe Harm Reduction Model. Carolyn. So the Indigenous Harm Reduction Model. So according to Martin and Maberbu in 2000, they were sharing knowledges and skills, experiencing new ways of knowing, being, and doing emerged. Developing a deeper understanding of cultural collaboration is one way of addressing complex health problems and building a capacity of health workforce. When we're looking at Indigenous ways of knowing, or Indigenous ways of being, knowing, and doing, we like to look at what that really looks like. So when we talk about Indigenous ways of knowing through collaboration, these are ways that are a social process of learning that are social, political, historical, spiritual, and taught and learned in certain ways in certain times. Ways of being and building relationships refers to the process and experience that recognizes the self, is experienced and constructed in the relations of others. And when we look at ways of doing, this means achieving outcomes. The ways of doing are accumulation ways of knowing and being. Ways of doing guided proper forms of conduct are an expression of individual and group identities and roles, and appear to be critical dimension of how successful cross-cultural collaboration is demonstrated.
We can't hear you.
Good afternoon.
It's very faint.
Is that better?
Yes, that's better.
Okay, thank you. Sorry about that. So the Indigenous Women's Cultural Safe Harm Reduction Model. You can see that on the top, we have the Kotaway, igniting the fire, the name of the team. Then we have the navigators, such as myself and my coworker Sterling. Then we have the Willow Warriors, the 7 Willow Warriors involved in the project. And then the cultural intervention practice on the side. So it's 4 and it's in a circle. What we like to say is that we want them to help themselves first, and then we want them to help their children, and then we want them to help community, and then go into harm reduction. What we like to hope for is that the Willow Warriors who have lived experiences how to help other women, support other women with similar barriers, navigating them through systems, and dressing up the ceremonies.
We can't hear you.
It creates a strong system of empathy. Okay, all right. So we like to have the circular in terms of everything is in a circle and goes full circle in terms of helping each other. So what we like to help them first and get them situated, and then as this project goes on, these circles are going to overlap and it's going to get wider where the women are going to help other women.
Miranda, we can't hear you very well. You need to speak as close to your microphone.
Okay.
Sorry about that, you guys. We were trying really hard. It must be keep cutting out. I hope you can hear me now. Does the audio sound better? So just kind of going off from what Carolyn had spoken about, our harm reduction model, it really focuses on Kotaway, which is the lodge that provides the Indigenous services, the access to culture, ceremony, and medicine. And most important are our navigators. And our navigators play a very crucial role to the frontline work that helps the women and that also implements these teachings as well. The Willow Warriors are our co-researchers, but the Willow Warriors are those who this model helps and assists with. And then we go to our cultural intervention practices. And our cultural intervention practices are the intervention to helping the women rehabilitate themselves and build those relationships, not only with their culture, but with their community and their home fire as well. Looking at this slide here, kind of tells us the layout of our research project. So the project's intervention was built around cultural intervention practices, and we're looking at a duration of 36 months of the Willow Warriors participating in the ceremony and the research project. With that 36 months, myself and the navigators were able to see a change of rehabilitation, a change of responsibility, and not only that, but a change of relationship, not with themselves, with the group, and not only that, but with community. And we found that that was probably one of the biggest things that we thought was important when applying cultural intervention practices. Again, the method that was done during this research is based on the agreement in the equitability of opportunities, which honors the culture, language, and traditions. This work is grounded by the knowledge and cultural practices of Treaty 4, where Regina is located, guided by the principles of community-based research and the 2I seeing as well. So our evidence has proved that long-term for women is definitely engagement and navigation to spiritual support. Co-development for both community and this is for roles in nation building. This research has informed.
Miranda, we can't hear you.
Can you hear me now?
Yes.
So, yeah, just kind of going back. So the idea of this research has to inform the influence of new ways forward for Indigenous health that is grounded in, informed by, and analyzed through Indigenous worldviews and theories. This project is about laying the foundation for implementing more comprehensive programs for research focused on women's and girls' and rights and roles to determine the impact of the CIPs of how the cultural intervention practices influence and experience the health and well-being over time. The long vision is to amplify the impacts of this project for Indigenous people living in Regina through an integrated intervention research agenda that focuses on nation building with families by integrated the research with the women and the men into a way of being that supports families and children. We will build on what the women have taught us through this research and the data that is delivered to sustain opportunities for them to learn and grow so that they can always quote away themselves after the research or after the project. I would like to thank everybody here. I'm sorry for my technical difficulties. I would also like to thank my Quotaway team and acknowledgements of my collaborators as well. And then also of all the funders and supporters during this research journey.
Thanks, Miranda. That was a very nice presentation and very informative. I do not see any questions in the chat, but I do have one question for you. I think Kotawe is a potentially impactful intervention. Do you have any thoughts on the future perspectives with regards to scaling up Kotawe? How can you make this reach more people than the 9 women you started it in?
I think one of the things that we want to see Kotawe is becoming a toolkit and being able to provide to different communities so that they can have the proper supports, and not only that, but the agenda to move forward with the work that we're doing here. Because I want to see Kotawe not only for women and children, but for men as well. And I think it's a good tool that will help Indigenous people across Canada with rehabilitating themselves, especially when it comes to those substance uses and living with that. And the chronic illnesses as well.
Wonderful. Thanks, Miranda. You have ignited the fire and now it will never go off.
Thank you.
Ladies and gentlemen, we've come to the end of this session. Thank you so much for your kind attention. We will now recess for a break, and I hope I will see you all at some other session. Have a nice day.